guys. Well, my name is John. I hope you guys know me. I work in the skilled nursing unit, and I usually do education. And I don't remember like onboarding you guys though. When were you hired?
January 2023?
Oh, 23. Was I there? Did you see me there or no?
Yeah.
Okay. Okay. All right. I should have been involved in all your new hires. In any case, there's so many new hires that I forget a lot of spaces too. I have in service in GHC on Wednesday at 2:15. So if you guys are CNAs, you want CUs, you can make those up by going into the in service, or you can come to me and try to make it up. And you do have to watch the videos that I have if you do miss it. So regardless, you're going to be spending some time if you have CUs. How many of you ladies are CNAs?
Nobody.
Nobody. Okay. All right. So I'm going to try to make these in services. These in services are designed for skilled nursing residents. So there's a different guidance for each department. We are overlooked more closely with the health department and the California Department of Health than you guys, but you do have some similarities in terms of guidance on how to take care of your residents. Yesterday, Alma came to me and said that you guys are having some skin issues with the residents. Since we had the same population of resident, the age, we're gonna have that same problems with resident. So it's not like, hey, you guys are Alzheimer's unit, and then we're skilled nursing. We're gonna have a totally different type of skin issues. We're gonna have the same skin issues, except for residents over here, they're more frail, so they might have more a complicated skin issue. But for the most part, it's gonna be the same with what we're dealing with. We have different guidance, but ultimately on how to take care of skin is gonna be the same. Okay, so some of these things in here, I'm gonna jump over and not even mention because it's kind of specific to skilled nursing. But for the most part, let's take a look at, let's dive into why residents would have or is at high risk for skin issues or skin tears. For the most part, some of the things that we won't be looking into is care planning. We're very good about care planning in skilled nursing and sharing that with our nurses. But over here, I mean, you guys are pretty sure you guys do care planning as well, but you probably don't even really see it, right? It doesn't really fit.
We utilize the skin sheets here.
You do the skin sheets, okay.
Yeah, I mean, I care plan a lot. I do the care plans, I kind of overall as
Yeah.
residents, but like for them, what they bring us is usually they'll do a skin check for showers.
Yeah.
Or
But do they know like the care plan for the residents?
they're available for them to read out.
Okay, all right. Okay, good. Okay, what the whole thing with the care plan is that at least like we care plan if the patient has behavior issue, we care plan if the patient is refusing something, we care plan if the patient is not eating or drinking. All of these seems like, what does that got to do with skin? Those are big factors when it comes to skin. If you have a patient that is dehydrated, not eating, not drinking, if you have a patient that is confused, if you have a patient that's not eating, these are all factors that could influence the skin of the resident. So knowing the care plan of that resident is going to be pertinent to how you take care of these residents, okay? Some residents are just going to be a really high risk for skin breakdowns, no matter what you do, okay? The fact that they're not drinking is going to put them at higher risk for skin issues. Just a barely nudging it, and you're going to have skin tears with that resident who's dehydrated, okay? Because fluid and protein is going to be really important in keeping your skin nice and firm and elastic and prevent you from getting skin tears. On the other side of that, residents who doesn't drink or doesn't eat, has a low protein diet is going to be a really high risk. Okay, so let's go over real quick. Some of your residents that are here, our job is to prevent them from getting pressure sores. If they do have pressure sores, we want to prevent them from getting an infection or getting a new one, right? That's kind of like the same scenario that we have here in skilled nursing. Okay, if you have somebody that does have skin tears or a wound, our job as caregivers is to prevent infection and to prevent from getting worse and to prevent from getting another one, basically, right? Common sense, right? That's the same thing what we do here. If you have a failure to heal a tissue that's degrading, or you keep getting a new skin tear, or you keep getting new pressure sores, that could be a problem in terms of neglect on our end. Not only as nurses, but as caregivers. We all have a job to try to protect the resident. All of us here are going to be liable for that resident if we continue to have skin tears, especially pressure sores. Okay, pressure sores is one of those that depending on the resident's diagnosis, 99.9% of the time you can prevent it. Okay, and if you're not preventing it and it continues to happen, it's called neglect, guys. And we can get in deep waters with that. Okay, and we want to prevent those from happening. Okay, let's take a look at the risk factors why some people do get skin tears more easily or pressure sores. Risk factors for skin breakdown is impaired mobility. Just the fact that you're moving around, guys, increases circulation and increases your you kind of just laying down, contracted. Two people are contracted. If you're not moving around, you're going to be more contracted. I'm going to talk a little bit about contraction a little later and why that puts you at risk. Nutrition or hydration deficit. That means that you're not eating, as I just kind of mentioned when I started the in-service, that fluid is really important. Protein in your diet is really important when it comes to tissue. Okay, protein and amino acids, the building blocks of all muscles, and so these muscles, these proteins, plays an important factor in terms of keeping things tight and firm. Okay, and fluids, the same thing. When you're dehydrated, your skin is loose, it's not as bouncy, and you can get a skin tear. Okay, and so that's why sometimes when we're taking care of a resident, we look for skin tear. You see how my skin kind of just bounced right back? Patients that are dehydrated and are drinking a lot, it'll be like that. If there's nothing there to kind of make it elastic. Okay, so that puts you at high risk for skin tear. Okay, incontinence, bowel movement, and urine, those are all very acidic. Okay, if you let that resident sit on that, and you, let's say for example, this is the bottom, your bottom, right? Your butt is right here, right? It's covered by a diaper, and now you have urine that's sitting on there. And maybe it's 8 hours that's just been sitting on that. That urine is going to eat through the tissue. If you add pressure into that, you're going to have a nice blue, not nice, but it's going to have a really bad blue area first, then it'll turn black, and then it's going to open up, then you have a pressure sore. That's how pressure sore starts to build. Not only urine or anything that can eat it up, like anything acidic, but also a lot of pressure that's put on there. If you're not moving your patient around every 2 hours, you gotta have that pressure.
How quick can that happen? The whole skin?
So here's the thing, and people that deals with like litigations and lawsuits, they know exactly the time frame of when skin breaks down. Okay, it doesn't happen over time. So that's why when they say, hey, I have my mom that's been in assisted living, she's got these great big sores, and now they're just calling me that she's got this big open sore. It happens for a period of time. It first starts off with redness. The first few hours, right? It doesn't just break down within 8 hours. It doesn't break down within a shift. You can still, then if one shift messed up and didn't move the resident for 8 hours, you still have the next shift to deal with, right? It turns let's just say 4 hours turns red. After the next hour, it might turn a deeper red, okay? And then if you don't move for the next shift, now you're looking at 16 hours. That means now it's gonna turn blue and purple, okay? Within 48, 72 hours, within 3 days or so, you're looking at like tissue looking black. This tissue might still be intact, but it's now looking really black. A black tissue means that there's that underlying tissue underneath is dead, okay? So me, if I'm a lawyer, I'm gonna be like, you guys had all that time to prevent this from happening, okay? You could have moved her around. That means a significant amount of shift has passed through, and you guys haven't made a intervention. You guys are not keeping her, offloading her. So the number one way to prevent pressure sore, guys, is not only nutrition and moving around, but also offloading. Okay, you want to take that pressure off. Okay, and the max amount of time you can keep a resident on one side, it should be 2 hours if they're immobile, right? Especially if they're incontinent, you should be checking them every 2 hours or so, kind of moving them around.
If they're on in bed a lot, like I was telling you guys, if they're in bed, like room call that used to be here, we gotta keep moving her because she just sits there. I know she skips meals, but it's always good. We gotta keep checking in to breathe and every 2 hours.
Just like John explained, it's only a matter of like within hours that can keep on progressing and go to worse, right?
Yeah, and so you start, the first shift might turn red, right? The next shift might turn a deeper red. Then the next shift within, right, the next day, 24 hours later, it might turn like blue or whatever. Okay, within 48, 72 hours, it might start turning black. If you're not moving that resident, that tissue, because you need circulation, the circulation provides nutrients to the tissue, right? But if you're constantly putting pressure in there, there's no circulation to that. That tissue starts to die off. It turns black. Okay, but everybody knows in the nursing world that took a while to do that. So we have different shifts, right? So we all had our duty to basically say, hey, this is turning red. So I'll go over some of the things in a bit here on how to like spot things that say, oh yeah, this is looking bad. Okay, instead of saying, oh, it's kind of red, that's usually red anyway, it's gonna be fine. You know, if it's red and it's underneath the bone, like coccyx, underneath the heels, in the back of your scapula, if it's red because there's bone there, and it's pressing it down, and we're not moving it around. Okay, we should be moving that resin around. Incontinence, we talk about that. Okay, impaired blood flow, I mean, that's pretty common sense. Somebody who doesn't have a good blood flow, maybe have impaired kidney, they have a CHF, which is congestive heart failure. That's going to play a factor in terms of resident who might be high risk for skin breakdown. Also, patients that might have diabetes, right? Their skin desensitized to pain or pressure. They can't really feel the pain. They don't have a feeling like in their foot, right? Because they're diabetic, right? Diabetic patients, over time, they have these high blood sugar, and it basically kills off your nerve. And now you don't have sensations in that area. If you don't have sensations in the area, especially your foot, you're not going to be able to feel pain there. Not even able to feel pain, you're not going to be able to move your foot. You end up having these ulcers, so diabetic foot ulcers. And so if you're diabetic, if you're dealing with a patient diabetic, always make sure that you're looking at their foot. Okay, because that's the one that they neglect all the time. They're fine because they're looking at everything here, they're okay, you know, there's nothing wrong with my hand, but your foot is way down here, they're not going to be able to see it. Okay, so always look at that when you're dealing with diabetic patients. Excessive moisture in skin, we know that's called MASD, moisture-associated skin damage. Over time, you can have fungal infection in there, so always try to keep skin clean and dry, okay? Dementia, patients that have dementia have cognitive impairment. These patients that have a high risk because they have really poor safety awareness. They'll run into things, bump into things, lock themselves in the room. You guys know, this is what you specialize in. So these residents already, when they come in here, they're high risk. Okay. Drugs like steroids, impaired wound healing. So drugs, when you have somebody that's on like steroid cream, right? They're putting it on for itching or whatever. Just know that cream is going to break down those tissue. Okay, any steroids. My daughter has eczema. We give her steroids. I try to give it like once a month, and then because she has eczema, right? But you don't want to be giving that too long because it degrades the tissue in the skin, right? You also have patients that refuse those treatment. You have a treatment for this resident, you're usually cleaning it, but they refuse. That's very difficult for, in that sense, to take care of that resident, and that can put them at high risk for skin issues. Okay, peripheral vascular disease. These are patients that are having issues with basically the same thing, like circulation. Restraint, any restraint, right? You can put in the patient against the wall, and they can bump themselves, they're trying to get out. So you want to be very careful with restraint because those could put them on high risk for skin breakdown. History of skin breakdown, anytime you have an ongoing issue with like a buttocks or something like that, where it's usually like falling apart, that tissue is already weak. So any kind of pressure on there, any kind of acidity is going to break down quite easily. And so a history of that skin being damaged is already going to put you at high risk. So if you're changing a resident and there looks like a scar on there, just know that scar could open up easily. Okay, for example, if she has a history of like stage 3 on there, when that skin breaks down, you're going to have stage 3 right away, right?
Do you guys know what stage 3 is and what it looks like?
Right. Okay, so the wounds, guys, is staged. Okay, so this is.
And a lot of our staff here, John, just so you're aware, they're newer to this field, so
okay,
this is why we're starting to do this.
Right.
We explain it a lot, but sometimes I feel like when someone else explains it a little bit, it's understand. But I mean, a lot of them are new to it.
So check this out. So if you have this is your bottom right here, right? You have a pretty thick, meaty area here. That it starts to turn red. That's stage 1. Right? If that top layer comes off, stage 2. When you expose the fatty tissue and the meat and all that, stage 3. And then when you expose the bone, stage 4. If you have a patient that has a nice covered area and there's a scar there, they had a history of stage 3. When the top layer comes out, it's already stage 3. It doesn't like, if it's a new tissue, basically you start off at stage 1, 2, and 3. But patients who's had a history of stage 3, when it opens up, it goes to stage 3 right away when it opens up. Okay, so that's kind of show you, once you lose the elasticity of that tissue, when it does heal, it's a scar tissue, it doesn't go back to the same. Okay, so it's very weak basically. Okay, causes of pressure, remaining too long in one position. Causes of pressure, for the most part, pressure ulcer is as it states, is straight up pressure, right? It's just, you have to offload stuff. You have to offload your heels, you have to offload your shoulder, you have to offload your bottom area, you have to offload your your hip, right? Frictions and shearing, when you're bringing the resident up, right? When you're, let's say the resident is sliding down their bed, right? If you, imagine this is them laying down, and then you pull them up like this, if they're dehydrated or they have really poor skin integrity, their bottom is gonna go like this tissue is gonna get ripped. Okay, now you have called a shear, and that for the most part it might turn red, but then ultimately it's gonna open up. Okay, so when you're lifting a resident up, make sure you, when you bring them up, make sure you're bringing them up and then lifting up. Because a lot of this sliding in the bed is gonna cause a lot of shear infection. Okay, and it doesn't happen all the time. You're like, man, I do it all the time. It doesn't happen. You will come to a patient, right? So most of your patient probably has good nutrition, is eating, is moving a lot. So it might not happen to them, but it does put them on a high risk. But if you have a patient who is malnutrition and dealing with malnutrition, is not eating and drinking quite well, they have certain medication that put them at risk. If you do that, it is gonna rip. Okay, so it just gives you more issues. Bad positioning in the chair, right? If you have patients that they're up, they're fine, I'm not gonna reposition them. Sitting down in the chair too long can also cause pressure sore in the bottom area. Right, braces and casts. You know, we don't think about like, these things. That patient has these braces, or arm braces, or leg braces. Those things, when they're put too tight, they can cause pressure areas. In areas where there's no bones, it's called pressure sores related to these devices. Okay, so we don't want medical devices. Okay, bad shoes, you know, that are too tight. If you have a patient that has these redness on their toes, maybe you might want to talk to your nurse and say, hey, you know what, let's get sandals on her, or let's just put on socks for now. So that way they're not, you know, the shoes can cause pressure sore, okay? So just remember that. Contractures, right? Patients that are not moving as much, they get contracted. So now they're, you know, they're having more pain, and now they're having more issues, right? When this is kind of like, yeah, when they're stiff, contracted, if this is like this all the time, you can have moisture here, and you're gonna have infection right? You can have fungal infection. Same thing with your leg when it's contracted, right? And so these areas can be very vulnerable to skin issues. All right, this one I'm gonna kind of skip. Care planning, kind of talked over that a little bit. But it's just important, like if you deal with, when you're going over some of the care plans, it basically goes over the resident's problem and what you should do in terms of intervention. That's what care plan is. I know we don't deal with a lot of care planning, and David probably does most of that. But if you do run into care planning, it's basically stating what the patient's problems are and what we should be doing for that patient. That's care planning, okay? Pre-existing signs of pressure sore. So these things that you see that puts residents that might have a pressure sore, redness, purple or dark area, right? Remember I said it could start off as being red, and then it could be purple or blue and then black. That's exactly how these colors are going to present to you when you have somebody who might have pressure sore. So for example, I come in, I'm taking care of Mrs. Brown. It's shift number 1, right, AM. And maybe the patient's on hospice, is not really moving around. They're still eating and drinking. And what's your name, ma'am? So she on her shift, she's not shift. I noticed that when I came in, it's kind of red, right? So what I should do as a caregiver is I should tell the nurse first, hey, this is kind of turning red. I know she's not really eating and she's not really moving around. So what I would do is I would keep her off of that by using a pillow, right? So that way you're offloading, you're taking that pressure out, right? You're keeping her in bed, but you want to put a pillow kind of reposition her, okay? And then you want to monitor. If it starts to turn blue at the last end of my shift, then I would tell her, hey, it was red, now it's blue. That means that, you know, my technique and trying to reposition this resident is not really working. So 100% of the time, 99% of the time, you have something that's red and you're taking the pressure off, that redness is gonna go away. Okay, I guarantee you, because that's like 100% of the time, pressure sores related to the depression, you know? But if you're starting to eat more and drink more and then moving around more, that's gonna eventually help you. Okay, but if you continue to do what you're doing, like, you know, keeping them on the bottom, then that's obviously gonna get worse. Okay, if it starts to turn black, obviously you wanna, you know, continue to tell your, you know, your supervisor, but they should be calling the doctor.
We don't want it to get black.
Yeah, once
Yeah,
it's black,
you know, red.
it's already dead. Okay, and that tissue underneath is already dead. Okay, and what you're worried about is that that's gonna open up eventually. You can have infection, and also it's gonna get to the bone. People die from bone infection. Okay. All right. Well, some of the, you know, what are some ways to prevent pressure ulcers? We kind of talked briefly over it. One of the main things you can do is reposition your resident and get them to move around. Okay. Provide measures to decrease pressure, is what we said. Keep skin clean and dry. Okay, the moisture is a big issue when it comes to, you know, protecting the skin, right? You don't want to start brewing some form of microbes on there because of it's moist, right? If you keep it nice and clean and dry, you should be good. Changing contact as soon as you can after avoiding a bowel movement. Apply protective barrier. What kind of barrier? Do you need order to apply here in assisted living? When, like barrier?
Yeah, usually we get an order for calcium.
How is it then? Okay.
Usually what we do here is that they report redness, I'll report to the doctor,
Okay.
and you'll say put some barrier cream.
Okay.
So we'll put a little treatment order
Okay.
after every change,
Okay.
barrier cream.
Okay. So if you have something that's red, right? You be proactive. If you have something that's red, especially the bottom area, there's a couple of treatment you can do. Obviously, reposition is number one, right? Moving around is number two, if they can. Increase your protein and your drinking is is the next one. But some of the things that you can apply is lotion. Lotion is good, but if you really want to prevent, if you really want a good barrier, right? Your skin is red and you need something to protect it. Camelceptin is thick, right? It's a cream, right? It's thick, so it would help you, right? In comparison to like a lotion. A lotion is nice, it keeps you kind of moisturized, but it dries up quickly, okay? What you guys should do, you need order for A&D as well here in assisted living or no?
No, we can.
Okay, A&D guys is your best friend, okay? When you see something red and dry and cracking, apply A&D on everything. Your lower legs, your bottom area, okay? Because A&D is an ointment, and if you compare it to lotion, it lasts longer, right? It basically keeps your dry skin or bottom area moist a lot longer than a lotion. A lotion will dry up within 15-20 minutes. That A&D, because it's an ointment, is gonna last longer, right? It keeps that area less dry for longer periods. Okay, so if you have A&D, what I have seen in some of the facilities before is that they always have A&D on the bedside. Okay, so that way, and especially like in these like tub of A&D, because like right before you get up your resident, you can take some of the A&D, put it on the bottom here, put it on the legs, put it on the toes, and it's great for moisturizing the area.
Have you guys ever noticed someone with really dry skin, like Susan, room 13, she does a lot of this.
Yeah.
So we have an order to put a little bit
Okay.
in between her hands. But if
Yeah.
you guys see heels, like John saying, we have it in that, yes, and always say, hey, you know what, can I get some A&D? And use it as lotion.
Yeah.
It's so greasy, but like John says, it protects it a lot longer than lotion does.
Maybe what I can do is give them some so they can have them in the cabinets and lock them in the cabinets or whenever they need it.
Oh yeah, because they could like be eating that, huh?
Yeah.
We have to lock it, that's the thing with us, we can't have it
Yeah,
like
yeah.
that side.
So you have to have it, so the problem that you have is that you want to have it accessible to your staff, but you don't want to have it accessible to your resident because they could be like eating it.
Yeah.
That's why we keep it, and they notice it in the mornings, or we already knew from the day before, you know, room 16 has really dry heels and stuff. In the morning.
It's a good practice, I can give you guys every morning.
Or you can,
Every morning I can.
before you start your shift, right, you can buy the A&D in a small packet,
Yes.
right? Before you start your shift, you can have it available up front and they can grab some, put it in your pocket, whatever, as you're doing it, you can apply them on, right?
Everyone.
Yeah.
A lot of girls, they used to put in their fanny pack,
Yeah.
and I know you guys don't use it anymore.
Yeah,
Our older ones that we have.
Yeah.
but I can't like even like begin to tell you how good A&D is for your patient. Their arms, their bottom area, their legs, their toes, these will help you with your residents that have these skin issues, especially your heels, guys. Your heels with your residents, you believe it or not, there's a lot of pressure on that heel, okay? And so those heels can turn red and have an open area really, really fast, okay? All right, edema. So edema is one of those swelling, right, on your legs. We don't really see it because when you're young, we don't have issues with it, and if you're not familiar with edema, you're not gonna see it as a significant factor, okay? The fact that you have water on your legs, does everybody know what edema is, right? This swelling on your leg. Why do you think that happens? Why do you think you have swelling? Why would you think? Is that normal to have water on your legs like that? No? Why do you think that happens? What are some of the things? Give me just a quick guess.
Heart.
You think it's your heart is giving up? That's big if it's a heart, right? Right? The circulation is bad, right? So if you see that, and it's something new, you guys deal with your resident on a day-to-day basis. If you see that it's something new, something big is going on with that resident, okay? Because the water, it gets pumped out by your heart, right? Through your kidney, you pee it out, right? But if you have a bad heart or your kidneys starting to fail, maybe, these water are going to sit in your dependent extremity, which is your leg, right? It could be sitting in your arm if you're not moving around, right? This is why it's important to move around, because moving around will actually get rid of these fluids, right? But if it's sitting on your legs, guys, if it's sitting in your legs, you have a muscle, right? And then you have vessels circulating the muscle. And these vessels provide nutrients to you, the muscle. But if you have water there, you're separating the vessel away from the tissue. Now there's no nutrients going to your tissue. Okay, so that's why it's very difficult to heal something when you have an open area in terms of like if somebody's edematous, you have a lot of edema, and now you have that water playing a factor, it's going to be difficult to heal something when you have a wound or a sore or a skin tear with somebody who has edema. Okay. On top of that, this patient is going through some cardiac issues. You should be promoting, calling, notifying David. But our job as CNA or caregivers, when we see something edema like that, is to raise that leg up. What is the raising of the leg up does? What does that do? Above your heart, right? What would you think that do to the fluid? If you raise your leg up and you're laying down in bed.
We have two residents we do it for. Could we explain it?
What do you think that does? What's the significance of that? When you lay in bed and you're raising the feet up.
The circulation and the water that goes down.
Yeah, so you don't want the water in your feet. So if you raise your feet up, it's gonna go back to your heart, and your heart can pee it out. Basically, brings it up to your bladder, and you can pee it out. Okay, but these residents who are laying down all the time, they're gonna have or sitting down all the time. These waters are gonna sit in their feet like this.
Room 5, that's an example of the doctor. Exactly what he said, room 5 doctor during the visit, that's what he says. It's, what did he call it?
Dependent edema.
Dependent edema,
Yeah.
he said, because does she move? No, she doesn't like to move. As we all know, she just wants to sit there like this.
Yeah.
We always have to pull her, so she's an example of that.
So the best way to do, guys, when you are putting this patient in bed, just raise the feet up. Make sure the feet is above the heart. Okay. If you're raising it just a little bit like this, and then the head is way up here, you're not doing anything in terms of circulating that fluid back up. When you have the head right here and the feet right here, raise the feet up above the heart. Here's the heart right here, right? You gotta bring that feet up. Okay, we'll bring that fluid back. Now the water from the legs is gonna circulate back down to the heart. The heart's gonna bring it out down to your bladder. Your bladder's gonna pee it out basically. And now you have less fluid in there. Okay, remember that fluid is attracted to sodium. So if you have a patient that's eating sodium all the time, asking for salt, and they have edema, you're not gonna get rid of that edema because you have a lot of sodium in there. Okay, so that's the other factor, is that watch what they're eating. Okay, so we're going to the weeds now, but I'm just kind of letting you know that edema is a significant issue, and raising the feet up is going to help you. Moving around is going to help you. And trying to kind of help your resident. Hardening of the skin. We're not going to go into that. Bogginess. These are basically symptoms that the patient might have if they have pressure sores. The skin starts to turn hard, like your heel, right? Your heel right here should be nice and soft. You should be able to push down on it. If it's hard, okay, and that tissue is probably dying in there. Okay, it's starting to turn hard. And then also the beginning of like a pressure sore is bogginess. It's like it's like fluid inside, right? So those are different kind of symptoms that the patient's tissue might be going south on. You might have a ulcer brewing. Okay, what are some ways to prevent pressure ulcers? We talked about this already? We did. Yeah, we talked about it. Okay, so let's talk about skin tears real quick. Skin tears. Okay, we know that patients' skin as they get older is gonna be pretty it's gonna be less elastic, right? They're more fragile. So any kind of bumps into to another wheelchair or to a wall, you're gonna have a skin tear there. Okay, so be careful when you do transfer. A lot of these skin tears are gonna be through transfer. Okay, the next insource I'm gonna have here is how to transfer resident. Okay, there's a technique that you need to do, but it's like a whole new basically in-service. And it has to deal with positioning the wheelchair, positioning yourself, where you should be when you transfer the resident, so you're not like bumping these residents. Imagine if you transfer a resident correctly, you're gonna, if you don't do it right, that leg is gonna be caught up in the leg rest. And most of the time, 90% of the time, guys, it's through that. We're transferring the resident incorrectly and we're nicking it into the leg rest, and now you have a skin tear. Or we're bumping into the shower chair, and now you have a skin tear. Or from the bed, right? We're bumping into the bed, and now you have a skin tear. Okay, so transfer technique is going to be really important. Okay, we know that as you get, like I said, as you get older, your skin becomes less elastic, less rigid. It sags. It kind of just hangs around, so it doesn't snap back as quickly, and so therefore you can have a skin tear more easily. Okay, and it has less ability to basically protect you from infection. Okay, and then you have less sensory on that area, basically. So you and I, we're young, we can feel a lot of things, right? You can close your eyes, you can have a lot of sensations. As you get older, some of these residents get kind of numb. So that way, if they kind of nick on something or if they push on something sharp, they might not even really feel it. You know what I mean? They have less sensation, okay? 80% of the skin tears happens in your arms and legs. If you have a patient that has a skin issue, frequent skin issues in the leg and arms, try to protect it by putting long sleeves pants, a sweater. I don't know if you guys have jerry sleeves or jerry legs. Those are things that they're a little bubble pack basically. They're like foam when you put them on the legs and your arms, it protects the residents. So those are stuff that we have in skilled nursing to protect our resident. But for you guys, you might think about maybe putting some longer pants, your sleeves, to kind of protect these residents' upper and lower extremities. Okay, so our main goal, if you do have, now we're dealing with patients now that have skin tears and pressure sores. What are some of our goals, you think? What's your name?
My name, Sylvia.
Sylvia. You have room, whatever, Mrs. Brown, right? And she has a skin tear, right? What do you think some of your main goals are for that skin tear, right? What are some of the things that we should be looking at as caregivers? If we're changing the resident, what are some of the things we should be saying, oh, this is what I need to do as a caregiver with this skin tear?
We have applied a lotion before and then check it up if they.
What if it has a dressing on it? What are some of the things we can do as caregivers? There's a dressing on it, right? I'm gonna change Mrs. Brown. My name is Sylvia. I'm coming in, and I see the dressing, right? What are some of the things that will tell us, oh man, this doesn't look good, or what are some of the things that I can do? I'll just tell you. As a caregiver, if somebody has a dressing, if there's a lot of moisture, if there's a lot of color in there, and it's like gooey, that's indication that the dressing needs to be changed. And it's probably infected somehow, or it hasn't been changed in a while. And so tell your nurses that, okay? If your patient has a fever, and I know you guys don't take temperature here as more often as you should, because it's RCFE. We don't take vitals.
We do
But
once a month.
usually somebody who has a fever, you're gonna be able to feel that, right? Like if you take it and say, man, she feels really warm. I do that with my kids all the time, right?
Yeah.
When they're sick and they're coughing, when I give them a kiss or whatever before I go to work or whatever, I can feel whether they have a fever or not. And sometimes I've talked to her a few times with her, man, she was coughing last night. I'm trying to say goodbye, and then now they're warm, and then I find out they have a fever. But as a caregiver, you should be able to feel that. Like, man, this Brown's really warm. Right. That's an indication that maybe if you have an infection, it's gonna show that you have a fever. Okay, so especially if it's a wound, right? You're gonna throw a fever in there. Okay, the other thing is if you're giving a shower, if there's a dressing there, don't get it wet. Because remember, we need to keep it dry, right? Clean and dry. So cover it with a bag, consult with your nurses to see what you should do with that wound. Because like I said, you don't want to get that wound wet, like the dressing, right? The less you tamper with that dressing, the more it's gonna heal. Remember that the tissue underneath that dressing is trying to heal. Okay, the more you rip it open, the less it's gonna heal because you're ripping the tissue out, right? Exposing it to temperature, getting it wet is also gonna slow down the healing. Okay. Larger skin tears may be difficult to heal, and they're more exposed to bacteria, and so they're higher risk for infection. So our main goal really, guys, and when somebody does have a skin tear or a pressure sore, is prevent it from getting infected, and prevent it from getting worse. And some of the things that we can do is observe the dressing to make sure that it's not like soaked, or maybe if they're not exhibiting a lot of pain in that area. If they are, that may be an indication that it's getting worse. And then also a fever, okay? Sometimes they may not throw a fever. If they start throwing a behavior issue, a lot of your dementia patients, they exhibit infection through an increased agitation, okay? So you might want to say, hey, you know what? She's usually not this agitated. I know she's confused, but she's usually not agitated. And now she has a slight fever, she could have an infection, okay? Okay, we talk about causes of skin tears, which is friction, right? When we're doing turning, transfers, dressing, bathing, ambulating, changing dressings, all these are factors of increasing your chance of getting infection. Rubbing and bumping against an object, bed, chair, clothing, dressing. That's our main issue here in this area, is that we get skin tear with transfers. And so next skin instance we're going to do is do transfers. Okay, ways to prevent skin tears: good positioning, turning, transferring, ambulating techniques. Use draw sheet. Use two-person, right, to transfer a resident to prevent skin tears, right? And not only that, to prevent your back from being broken, right? You can use arm and leg protectors. I know you guys don't use that. We use longer sleeves, longer pants, right?
At times we do use that tubing stuff.
You do have that? Okay, yeah. So if you have that, those are good to.
We don't always use
protect
it.
the resident. Use a pad for the bed. Make sure all wheelchair legs are out of the way when you transfer. Instead of folding it in, take it out. Take the whole leg out. Okay, because a lot of times you get skin tear because it scrapes it. I've noticed that. We turn it over like this, when we transfer a resident, that bulky part is still sticking out, and then you scrape the resident's leg, and now you have a skin tear. Just take the whole thing out. Okay, the wheelchair too has a side, the grab bar, both sides of that, the arm like this for the wheelchair. Both of these can usually 99% of the time it can be removed. So you can take this off, so the transfer is a lot easier. Okay. And then as we talked about, make sure you're using a lot of these A&D or whatever you guys use. Conceptin, ointments over lotion, right? Creams over lotions. Don't use lotion. Lotion is great for your hand or whatever, but if you're trying to protect something, use ointments and creams. Okay, because creams last longer, the more moisturized. They're a lot better than lotion. Okay. All right. Any questions? Any questions? I know we have a test here, guys. Did you guys fill it out? Do you guys have any questions on how to fill them out? Let's go over question number 1. List 3 risk factors for skin breakdown. Impaired mobility, incontinence, poor nutrition are some of them. What are 2 interventions to prevent pressure ulcers, turning, right? Keep skin clean and dry, keep bed linen dry and wrinkle free. So those are a few things. What should you do when you find skin tear? Obviously report it to your supervisor or med tech when they're here. And then list 2 interventions to prevent skin tears. Draw sheet for repositioning, head crank out of the way, wheelchair leg rest out of the way. Okay. So a lot of this stuff, skin tear, is just transfer. It's difficult. We gotta work as a team and have somebody help you out. I know you guys have radios here, right? You can use your radio. We deal with the same thing in skilled nursing in terms of working as a team, preventing injury, not only for us but also for the resident. Guys, any questions on skin tear, skin care? Okay. We'll do it again next week, or hopefully in the next coming week. We'll talk about transfers and how to do transfers again.
Do you think 10 works a little better for you? But just because they take their breaks at 9?
Yeah, 10's fine. Just let me know the time frame.
That's a long way.
Uh,
Thank you, John.
okay, yeah, give me, go ahead and put in your email here, I do have a, I'll have these available this